Good morning, everyone, and welcome to session 10 of our UNC Health COVID-19 Game Changers series. We're delighted to have you with us today. My name is Leslie Nelson Bernier, and I have the pleasure of serving as the president of the UNC Health Foundation. And we're just really excited for today's event. And I wanted to just make mention of the Q&A feature that's enabled for this call today. Although we can't see your pictures or hear your voices, I do hope that you'll take an opportunity to put questions for our speakers in the question and answer, using the question and answer feature on Zoom. And to start us off today, I would like to turn things over to Dr. Wesley Burks, who serves as the CEO of UNC Health, as well as the Dean of the School of Medicine, to give us an update. Dr. Burks?
So good morning, and thank you all for taking the time to join us. I'm particularly excited today to be joined by Dr. David Weber. David, that many of you know, is our Charles Addison and Elizabeth Ann Sanders Distinguished Professor at our UNC School of Medicine and one of the finest infectious diseases and infection prevention experts in the whole world. I feel personally very fortunate to have David here at UNC as a leader, both in our global response to the COVID-19 pandemic, as well as helping guide our university's response to all the kind of ups and downs and the craziness of the last 14 or 15 months. I really personally, as I've said many times, thankful that David is a colleague and a friend who I've come to know much better in the last 15 months. Personally, I truly can't imagine what this period would have been like for me and really for all of us here locally without David and his colleagues that have been guiding us. As I have during the previous Game Changer sessions, I want to talk a little bit about the current state of COVID-19. I know David, as he talks, will address it broadly, but just specifically in our UNC Health system, after the November through January significant rise here and across the country, there was a really sharp decrease in the number of patients in our system that started later in January. The numbers leveled off several weeks ago, but now really in the past couple of weeks, the people in the hospital have gone up about 40%, which is not unexpected based on predictions. As the vaccination efforts have gone through, we're observing the shifts, as you can expect, in the COVID inpatient demographics. The current median age for hospitalized patients is 61, which is way less than it was. And we've seen an increase in that 50 to 64-ish age range that we didn't have previously. The good news is that the number of people over 75 in the hospital has decreased and the mortality is significantly different. From the vaccine standpoint, UNC Health now has given over 350,000 vaccines. Statewide, we're approaching about 6 million to have gotten at least one dose. So as you step back a little bit, it really is remarkable to think that less than a year and a half ago, when we hadn't heard of this disease specifically, that a vaccine, or really vaccines, had been developed, and now we've been able to give immunizations to this many people. That's really the amazing part of all of this. The last week, I know you've read about the J&J vaccine and the pause. We did that in UNC Health following the federal guidelines. Those that were getting ready to receive it have been offered other opportunities following up on those that did. We've not specifically seen those adverse reactions that it was stopped for. It'll be interesting, as David talks about it in a few minutes, what he anticipates will come out of the CDC and the FDA related to it. So as the school semester for our undergraduates and graduate students is coming to a close, I want to acknowledge the hard work and the dedication of our faculty and staff, students at the school, who've adapted remarkably for really a year of very different educational experience for literally all of them. We recently celebrated the match day for 2021. Again, it was done virtually. For many of those students, they are now going places they've never been to other than by Zoom. And you can imagine, one, the stress of that, and two, how difficult that might be. So, but we're excited for them, their next generation of physicians and providers starting their change. their career, the changes that they're going to undergo. So as we started now, the other game changer sessions, I want to ask David, like I've asked others, how are you doing personally now, way more than a year into the pandemic? So David.
Well, on a personal basis, I should say there have been some silver clouds to COVID, one of which is my oldest daughter and family and youngest daughter and boyfriend have moved down to the Chapel Hill area. They live in DC to work remotely. So I get to go home every night and play with my 2-year-old granddaughter who's living with us. So that has been a wonderful experience. The other thing I will say is, of course, I've spent my whole life in infection prevention and in pandemic planning. So, I want to say that under your leadership, UNC has just done an amazing effort. I'm so proud of UNC and all my colleagues, and I'll mention that when I talk all the accomplishments we've had in keeping our patients and our colleagues safe. But I personally am doing well, and just so thankful to be here at UNC, the leading research institution for COVID and SARS in the nation.
Well, David, thank you. And as they're getting ready, the slides to come up, I'm looking forward to your presentation today and the discussion that we'll have afterwards.
Good. Well, thank you very much. I'm going to give you split this talk into two pieces. Some of this was already mentioned by Dr. Birx. I just want to put the current COVID surge into perspective. You can see here that we're still in the first wave, unlike the 1918 flu pandemic, which had months in between each wave. We've really never gotten out of our first wave, and we're beginning our fourth surge. Many people, and appropriately so, were very pleased to see the drop from 200,000 cases at our peaks in January down to only 50,000. But keep in mind that the current number of cases are coming back up, and they exceed the number of cases we were having either during the first or second wave. So unfortunately, more than 50,000 Americans are developing COVID each day, and hundreds are dying. So the total number of cases in the US of COVID, CDC has stated, is about 31 million, with more than 550,000 deaths. The good news is that about 125 million, or 37% of the US population, have had one dose, and roughly 25% have had 2 doses of vaccine. And we're delivering vaccine at about 4 to 5 million doses a day. Unfortunately, the average death rate still remains immensely high, 700 people a day. Keep in mind, I want to put that in perspective. It's like 2 jumbo jets crashing every single day, and this has been going on for a year. The data from 2020, by the way, showed that SARS-CoV-2 was the third leading cause of death after heart disease and cancer, and depending upon where we are in surges, it's often the leading cause of death in the United States. The driving factors for increased cases are elimination of mask mandates in some states, increases in the SARS-CoV-2 variants, which I'll talk about, and spring break. Overall, roughly 35% of the population has either had natural disease or fully vaccinated. In order, as I'll mention later on, to get to so-called herd immunity or community protection, we have to reach the level of 85%. So we really have a long way to go before we start seeing that. Before I go on and talk about here are the deaths rate, just mentioning with COVID-19, unfortunately 350,000 people in 2020. By the end of May, the total number will be 650,000. So a horrendous toll of misery of death. I do want to mention some of the things about UNC and how we're leading the United States in COVID mitigation and research. I just looked it up, and as of today, the IRB has approved 454 human clinical trials for COVID. These are not counting any of the basic work that we also lead the country in with Ralph Barrick's labs and many others. but truly amazing number of clinical trials to better understand the disease, develop better therapies, assess the current therapies, develop vaccines there. Also, since January, we've had up and running a post-COVID care clinic. I'm not really talking about that under John Barada from Physical Medicine and Rehab. This is one of the first clinics in the country to recognize and deal with the fact that up to 30% of people who have had COVID have symptoms, so-called post-COVID sequelae or long haulers that can last for months. And as of today, that clinic has already seen 140 patients and then has the ability to refer them to any number of subspecialties, cardiology, pulmonary ID, psychiatry, depending upon the nature of their problems. I just received a survey done by my professional society, Society for Healthcare Epidemiology of America, and less than 15% of similar academic hospitals have an up and running post-COVID care clinic. So again, we're leading in that aspect. Next slide, please. So this is what I want to do is talk to you about variants. You can see in the upper left, this is a slide that Dr. Barrick lent me. You can see that the D64 strain has been replaced by the G614 strain. These new variants in general are more infectious, but they have other aspects to them. They are mutations in the spike protein, which is how we develop our immunity and how all the current vaccines develop immunity. They're more transmissible in laboratory studies, in cell culture, hamsters, and humans. And depending upon the particular variant, some may be less susceptible to vaccines and monoclonal antibodies. Of particular concern is the UK variant with increased virulence, and the South African one with some escape from vaccines and monoclonal therapies. All of them have increased transmissibility, and I'll show you some of that data. Next slide. So what are the implications of these new variants? Well, some certainly spread more quickly in people. The UK variant is probably the most transmissible of that group. It is approximately 50 to 55% more transmissible. People have higher viral loads, and that probably accounts for that. And it's the most dominant variant in the United States at the present time. And this is and one of the reasons we're seeing the current surge. They may cause a milder or more severe disease in people, and the UK variant is felt to cause more severe disease. They can evade detection by some viral diagnostic tests. The tests we use will pick up all the known variants, but some of the older tests will not pick up, for instance, the South African variant. They have some resistance to monoclonal antibodies. I'll show you that. And some have led to decreased effectiveness, and I don't want to say non-effectiveness, but decreased effectiveness of vaccines. And those are the South African and the Brazilian variants. But that is, at least at this point in the US, are uncommon. And of the most concern are the variants that have decreased ability for the vaccines to work and monoclonal antibodies. Masks, by the way, are perfectly protective against all the variants. The basic nature of the virus doesn't change. They're all susceptible to alcohol hand rubs, and they're susceptible to the surface disinfectants. Next slide. So here are the SARS-CoV-2 variants. There's our coronavirus, and it has an RNA genome. And really the key variants are with mutations in the spike protein, which is the immunogenic part of the virus. Other viruses that are mRNA viruses like flu, you're all aware that that virus can mutate quite readily as well. Next slide. So here I know, first of all, happy to make all these slides available to you. The variants of concern are listed in the upper right. The B117 is the UK variant. The B135 is the South African variant. The P1 is the Brazilian variant. There are variants in New York and California that do contain mutations of concern and may also spread more rapidly. And this may be one of the reasons for increased spread in California. And then there are specific mutations. Now, keep in mind, a variant may contain one or more mutations that confer different aspects to it of clinical importance. Next slide. So the way the CDC groups these are variants of interest, variant of concern, and variant of high consequence. There are 5 variants of concern in the US. Those are the ones I've already mentioned. Fortunately, there are no variants of high consequence yet that have been described. And CDC is now tracking all of these 3 and now has a scheme for how they classify the different variants. I should say not all these variants have developed outside the US and moved to the US. We have our own homegrown variants, the California variants, and the New York variants with increased transmissibility. Next slide. And again, the variants of interest I've already mentioned, but the top is the New York variant reduction for some of them that they may not be as well treated by monoclonal antibodies and convalescent serum, which is of concern there in their variants. And most importantly, the P2 variant in Brazil is of interest. Again, decreased ability of the monoclonal antibodies to provide therapy. Next slide. Now, most concerning are the variants of concern. Again, we've already described these, but these have increased transmissibility. You notice the UK variant is 50% increased, as well as a 30% increase in morbidity. And this overlaps a little bit with the variants of interest. Some of them will affect diagnostics. We monitor that. All our diagnostic tests will pick up these variants. Next slide. And then we have the variants of high consequence for these, which would be demonstrated failure of diagnostics, demonstrated failure of vaccines, or disproportionate high number of vaccine breakthroughs, reduced susceptibility to multiple emergency use approved therapeutics, a much more severe clinical disease. And such variants do require notification to the WHO and the CDC. But fortunately, at this point, there are no SARS variants that rise to this level of high concern. Next slide. So if you look at the CDC, you can see that now, unfortunately, CDC has not entirely put in the denominator numbers, making it a little hard to judge the impact. But you can see that the B117 variant there, both in the upper left and then in the right, it is in every state in the United States, essentially. And it is the dominant variant in the United States. And again, higher transmissibility and higher morbidity. Fortunately, only relatively small numbers of the Brazilian variant described in the U.S. at the present time, but still concerning for the future. Next slide. Now, this is our data here at the medical center. A couple of things I want to point out to you. First, over the last several weeks, 75% of all our cases at the medical center among students or among our patients have been variants. We do sequence and have for a number of weeks every single SARS case in the that occurs at the medical center. We have 740 sequenced. If you look at the upper right, you can see these are the different variants I've mentioned, both in North Carolina and at the UNC Medical Center. And I want to point out to you, not only have we sequenced more strains here just at the medical center than the entire state of North Carolina has sequenced or sent to the CDC, but we also pick up a number of variants because of our improved techniques that have not been described in North Carolina. For instance, the 427 and the 429 strain and the 526, 525 strains, the New York and California variants, really have not been described in North Carolina, but we are picking those up. And we've picked up small numbers in the medical center of the Brazilian variant. And then we also break it down not only by variant, by what specific mutations they contain. This is just amazing work by Dr. Melissa Miller, our director of our microbiology lab, and again, just showing how North Carolina is leading not only the state, but the nation in its ability to respond to COVID. And this is enormously helpful. On the basis of this data, for instance, we have now prioritized which monoclonal antibodies we use, picking the combination of, there are 2 different companies making multiple monoclonal antibody products. We've picked the product as our preferred product that will work against these variants, has better activity against these variants. Just because we have this data, it's already helping us make therapeutic decisions. Next slide. So here's our data over time here at the medical center. In green is the total. In light blue is the UK variant, which you can see is approaching 50% of all our isolates. In pink is the New York variant, which is sort of bouncing up and down, but between 20 and 30%. And to the right, the different mutations. And this data has a small lag, about a week from when it occurs. But as we get better at doing these tests, we hopefully can eliminate that lag and actually use it for making clinical decision making. Next slide. Again, the variants here, just to point out the three-dimensional picture of the spike protein is known, and we know where the mutations occur. And based on that, we can make some estimations, even without studies, about how these will affect vaccines and monoclonal therapies. Next slide. There. Just the some studies, their variant study, the UK and South African variants there. And just to notice that the B117 strain from the UK, it does work against most of the monoclonal antibodies. There is a slight difference in how well it works, but it does work and is susceptible to all the monoclonal antibodies. But the South African one is markedly more resistant to neutralization. And at the end, you can see by vaccine sera, it takes about, it's about six-fold higher amount of antibodies from the vaccine to neutralize it. Fortunately, the amount of vaccine we get in terms of antibodies is more than 100-fold over what the minimum amount is necessary. So it will still work, but maybe not quite as well for these so-called escape variants. Next slide. And here you can see the different drug susceptibilities that in the combination product, the two monoclonal antibodies on the left, there is no change in activity, whereas in the Regeneron product on the right, it is somewhat less effective. So knowing which variants we have and having this data, we have prioritized use of the variants to the left, the monoclonal antibodies in our therapy for patients. And we have one of the most active programs for providing monoclonal therapy. It has reduced, we give it to symptomatic patients who are at high risk of progression. Our rate of hospitalizations in those patients is only 3%, which is dramatically lower than the expected 6 to 10%. And our rate of mortality is 0.6% in that group of patients, which is a dramatic reduction as well. So using these therapy, which we've done widely, keeps patients out of the hospital. And if they're in the hospital, largely prevents them from dying. I think this was my last slide on variants, and I'm happy to answer any questions you have.
So, David, I'll ask as people are either typing in the chat box or in the question answer. One of the questions was just some feedback on the statistics on the average age of deaths and then the trends over the last few months.
So what we've seen in our cases over the last several months, going back probably 6 months, is less cases of people over 65 and more cases of people, in the 20 to 49-year-old age group. And that's what is largely propelling the current outbreak at the present time, is the younger group, not young children, but young adults not wearing masks and being infected. But our death rate, which has dropped somewhat, still is mostly older individuals or people with comorbidities. More than 50% of the deaths are in older individuals, and actually 90% if you include age and comorbidities such as obesity, diabetes, immune suppression. Roughly 90% of our deaths are in people with a comorbid condition.
Okay, another question that had been submitted earlier was, as you think, and you've talked to us about the different variants that are there, what impact will that have, or if any, on us needing booster immunizations from the different vaccines?
So Pfizer and Moderna are already working on developing booster vaccines. Of course, their current priority is to produce enough vaccine for every American to get the initial primary series. I think once that happens, they will turn towards producing booster vaccines that will, one, boost our general immunity, which is broad, and we have many different antibody classes, as well as be specifically tailored to cover some of the newer variants. And I would guess sometime in the 6-month to 1 year range from now, it will be recommended that we receive one booster. Many people ask, will we need boosters every year like flu shots? My own guess is probably not. Keep in mind, whenever an American gets infected, and this is true worldwide, we all are little factories for developing variants. So if we can immunize enough of the population to drive the number of cases down, that will slow the number of variants that are circulating and slow the speed with which we might need boosters. And in general, coronaviruses mutate about the third the frequency of influenza viruses. So I think we may need periodic boosters, but I don't know that we're going to need yearly boosters.
Okay.
And I should say we have good evidence boosters work. The best evidence comes from giving vaccines to people who have had COVID, and actually COVID disorders the immune system, and they get an excellent boost response even after natural infection with a single dose of vaccine.
Okay. Another question that was submitted is, can we reach herd immunity without vaccinating children?
The answer is that's going to be very difficult to reach that 85% level. Pfizer has already submitted to the FDA a request to expand their lower age from 16, lower it to age 12. I think their data is excellent, what I've seen, and I would expect that to be accepted in the next 4 weeks. So we will be able to immunize high school students, I think, by early summer. Unfortunately, studies are just beginning for 6 months to 11 years of age. I think we won't have a true childhood vaccine until late till the fourth quarter of this year, early next year. I am most worried about issues like what happened, the concerns about the Johnson & Johnson vaccine that will lead to vaccine hesitancy, and therefore we will not reach so-called community levels because of people unwilling to accept any vaccine, including the Pfizer and Moderna vaccine, which have not had the clotting problems of the Johnson & Johnson vaccine.
Okay. Another question, David, that somebody just submitted is about, could you tell us a little bit more about the mutant strain from India, the B.1.617? And then the second part of the question is, if you could talk a little bit more about children and how they're impacted by the disease.
So yes, there are many, many variants described all over the world. The one in India is just another variant. And again, we have not had any of the most highest consequence variants, but most of these variants have increased transmissibility. And some, as we've mentioned, including the strain in India, may have some escape from monoclonal antibodies and vaccines. There, in terms of children, I'm actually working with our colleagues at Duke, and we meet weekly with the superintendents of the Orange, Durham, Chapel Hill, and Wake school systems, and we have made available through what's called the ABC Collaborative a great deal of information to schools. I do think that with mask wearing and some physical distancing now down to 3 feet for schools, most schools can reopen at least partially. These are grade schools. I think that this period of obviously of COVID, the biggest effect will be not on very young children, 1, 2, 3, 4. I think obviously that will slow socialization through daycare and others, but those kids will pick up very quickly. I don't think there'll be lasting impact. Clearly more impact on school-aged children as well. And there is no question about children as well as adults, increased concerns about psychiatric illnesses, one harder to see care. Depression, anxiety, and more severe illnesses like schizophrenia have certainly been a major issue there. And I think we will have to deal with children with more behavioral problems, slower learning issues. We have yet to really study how best to meet that. Another thing that's understudied is, I talked about the long haulers. We have a very good set of data now on young adults through older adults with that, but we really don't have any data whether having had asymptomatic or even mild COVID disease in children, whether there'll be any repercussions in terms of learning disabilities or other issues. That's something that clearly needs study. And I think even if the cases go down by June or July, we as a society really need to invest in studies which are being done and to think about COVID as a long-term medical and public health problem that will be with us, the sequelae, for years.
So David, in follow-up to the news last week, there was they showed the data about roughly 5,000 people had gotten COVID after a full vaccination out of like 66 million. Talk a little bit about that and that expectation of that and what you get out of that information.
So the good news is the COVID vaccine in clinical trials was 95% effective, at least the Moderna Pfizer vaccines, for preventing infection. The Johnson & Johnson vaccine, as well as the other two, essentially 100% effective for serious disease, meaning hospitalizations and deaths. We now have excellent data from Israel, which is one of the leading nations in vaccination, looking at 600,000 vaccinated people and 600,000 controls. And in the real world, the vaccine effectiveness was also very similar, meaning 95% effective. The bad news, of course, is that 5% of people, if they don't adhere to masks and physical distancing, could get infected. But even within that small group, the vaccine does work to ameliorate the disease and largely prevent hospitalizations and deaths. So that is good news. But one of the take-home messages, particularly if you're in a higher risk group by virtue of age or underlying comorbidities, you still need to continue staying within your household bubble, and when you're in larger groups, wearing masks.
Okay, so this other question I'll walk through is related to a person getting a vaccination after having disease. And one, what do you recommend that they get it? Two, what happens to their antibody response with the vaccination process if they've had the disease or not have the disease, how to compare them. And then how comfortable will I be around someone who's had the disease, not been immunized, and I've been immunized? Am I going to be okay to be around them?
So yes, we do believe, because normally you get a better boost of your immune response from natural disease from a vaccine. This is unusual in that the vaccine is giving you a better set of both antibody response, and you get some T-cell mediated immunity as well than the natural disease. And that's probably because the virus itself does disorder through cytokine storm and others the immune response. So people who have had COVID should wait until they're no longer infectious, so they're not a risk to the person giving them the vaccine dose, which is about 10 days, and people have not been hospitalized. Then it's safe for them to get the vaccine, and it's highly recommended that they do get the vaccine. They get a much higher and durable vaccine response there, even with a single dose. You are largely protected, even though the immune response is not quite as great after natural disease. You're largely protected for at least 6 months from getting infection. But people have become infected even after natural disease. Unlike vaccines, where most of the people who get infected after vaccine have very mild disease, there have been people who've been described after natural disease. Many have more mild disease on their second episode, but others have actually had more severe disease. Those tended to be older or immune compromised. So vaccine is actually a better protection than natural disease, but you are largely protected for 6 months after wild type infection. CDC, as you know, is now recommended that if you are fully vaccinated, your little household bubble, and you go to another small household bubble, you want to visit your parents or your children, that is considered safe. You can take off your masks and have dinner. They've made no such recommendations for people who have had natural disease or vaccine and natural disease. I think it would be largely safe, but not as safe as if you had vaccine. And I do encourage everyone who's had disease to get vaccine. People, CDC says you should still be wearing your masks and physical distancing in larger groups, or if you have higher risk conditions.
Okay, David, so I know there are a number of other questions. Why don't we go to the next part of your presentation, and then we'll leave time for more questions at that point.
Thank you. All right, so vaccines, Pfizer, Moderna vaccines provide 95% protection against SARS-CoV-2 in humans. We talked about the South African vaccine being a little bit of a decrease, but your antibody levels are well above that needed to prevent infection. Pfizer and Moderna are busy reformulating things. I should say Pfizer is already 1 month into a booster study with the same vaccine. So they're quite working hard on that. Some of the other vaccines, such as the Novavax, the AstraZeneca vaccine, and the Johnson & Johnson vaccine, clearly have been less effective when done in South Africa than they were done in the US. So that clearly is of some concern. Next slide. These are the principles for vaccines: maximize benefits, minimize harms, mitigate health inequities, promote justice, promote transparency. Everyone who's over 16 is now eligible for vaccine. So we're not using the phased approach anymore. Next slide. But I do want to point out to you, if you look at the vaccines side by side, the Pfizer, Moderna are mRNA vaccines. The Johnson & Johnson is an adenovirus vaccine. Johnson & Johnson has the advantage of being single dose vaccine, and actually in general lower side effect profile, little less effective in preventing symptomatic disease, but equally effective in preventing hospitalizations and deaths. There have been reports of dizziness and syncope, which are in the range of about 0.5 to 1%. We paused for 1 day in our use of Johnson & Johnson vaccine, developed new protocols to deal with that. It successfully reopened. And then rare clotting problems, which I'll mention in a minute, about 1 in a million. The Johnson & Johnson vaccine also has the advantage of being more temperature stable. Next slide. Here are the UNC Health sites we cover. You can see a large swath of North Carolina. You'll also notice a little van. We also have a mobile van providing vaccines to disproportionately disadvantaged communities. Next slide. Here's the data that Dr. Birx mentioned. We've given over 350,000 doses of vaccine, something on the order of just UNC Health, about 12.5% of all the vaccines in North Carolina. Notice we have another 35,000 people with future scheduled appointments, but that said and done, in the last couple of weeks, we have noticed the number of people seeking new appointments to be dropping. And so we need to renew as a public health issue, vaccine hesitancy, and UNC has been very active, both at the medical school and public health dealing with this. Next slide. In terms of COVID vaccine administration, just some data from statewide. I do again want to point out that African Americans and Latinos statewide have had less numbers have been immunized compared to their populations, but that's not true within UNC Health. We've worked very hard eliminating those disparities, and while they exist, they're much less than for the state as a whole, and they've rapidly improved over the last 6 weeks. Next slide. I do want to point out one of the issues about why the CDC has not completely said if you have had vaccine, you can just not go around, not wear a mask. We've already talked about 5% of people still get ill. It isn't fully known if you can be whether vaccine prevents you from getting infected and infectious, even though you have no symptoms. You can see a variety of studies now here listed, all between sort of 75% and 95%, demonstrating that the vaccines work from you even becoming infected. This is excellent data. Many of these are retrospective studies. The best study that's being done is actually being led by Audrey Pettifor, and it's in college students, a randomized controlled trial on 20 campuses. She's leading the entire study for the National Institutes of Health. She's a member of our School of Public Health here. The lead person for the UNC campus is Dr. Sylvia Beckett-Dreps, one of our family practice physicians. So again, UNC leading the study that will definitively answer this question. Next slide. Again, I just want to point out the study from asymptomatic infection and PFIZER. If you go down and you look at in the lower left, 7 days after the second dose, meaning fully immunized, preventing any documented infection, 92%, for preventing symptomatic illness, 94%. So it does appear that these vaccines will prevent infection, which is excellent news and may lead in the future as more people are immunized to further reducing some of the mitigation strategies. Next slide. And I just want to show you the data here for vaccine efficacy against asymptomatic infection. You can see how the red and blue lines diverge, demonstrating how well these vaccines work to prevent asymptomatic infection. Next slide. Response in previously infected individuals. I know we've talked quite about that. You can see here uninfected, previously infected, and you can see the post-vaccine response in uninfected. You get this huge response. This is on a log scale about there. And then you can see previously infected, you were similar to the vaccine response, but the vaccines are giving you more avid antibodies. And then you get this huge spike of additional protection when you're immunized. Next slide. And vaccine safety monitoring, there are 3 systems used by the federal government. There's the VSafe system, there's the VARI system, among others. So this is monitored, but they're all passive systems. Someone really has to call and report. Next slide. We have an active system here. The biggest news is on the cerebral venous thrombosis, sinus thrombosis. It occurs rarely with strokes. It's predisposed by oral contraceptives, pregnancy, malignancy, infection, and others. Most common presenting is sort of intracranial hypertension, seizures, encephalopathy, and a few other rarer symptoms. Next slide. But if you look at the number of vaccinations to date, 6.8 million vaccines to date of the J&J vaccine. The rate you can see is a little under 1 case per million population. There may be a little underreporting, but this does appear to be a very, very uncommon rare. There are a couple of reports with Moderna, but again, that's 3 out of 85 million doses there. Keep in mind, 550,000 plus Americans have died of the vaccine. So the overwhelming benefit will be to receive the vaccine. And I would expect in the next 2 weeks, they will re-release COVID vaccine with potentially some additional warnings. All the cases, by the way, were in females. Next slide. Even if you can't, even though there does not appear a predilection for people on birth control or others, but they were all in females. So what about the future? SARS-CoV-2 population genetics is large and global. We're clearly going to select for new variants, particularly more transmissible variants. We will need to change our vaccines and our monoclonal antibodies. That's being done, and I really think we will be able to keep up with newer therapeutics and newer vaccines so that in the long run, these variants will not be a major public health problem there, but it is of major concern at the present time. Next slide. So known for the future, I mentioned the large number of people infected. I do expect we'll have another 100,000 deaths in the next, reach that level, 650,000 people in the next several months. The variants will spread. It's hard to predict how quickly they'll develop, and we clearly will develop new therapies. Part of the problem for determining surges is holiday gatherings, Easter, 4th of July. What about summer camps? Will we have more drop-off in masking? There's people feel protected there. So those are all making predictions for the long-term future more difficult. Next slide. I'll just quickly go over this whole issue of herd immunity, although the term is better community protection. In the lower left is an infected person. Around them are all the blue people who are susceptible. You have a disease like COVID, almost everyone will get it at some time. Where we are now is that middle, where you have the red person who's diseased. In yellow are people who either have had natural infection or are immune or have had vaccine, but there's still plenty of susceptible blue people around. The people who have had natural infection or vaccine don't get infected. They're relatively protected in general, but it still spreads, and a few people who are susceptible are protected by that not reaching them. And then you move to herd protection, which we probably start reaching at about 80 or 85% there, where essentially it's cocoon. The infected person is completely surrounded by people who can't become infected. The reason we don't see measles outbreaks in the United States, because this is what happens. And the 5 or 6 people who remain susceptible because they had a contraindication to vaccine or chose not to take it are protected. But we are a number of months away from reaching that level, and I worry of that vaccine hesitancy will either delay or prevent that goal. Next slide. So here are just some estimations of how we get to that goal. As we go up to more vaccines, we reach it faster. If we ease up on restrictions, we reach it faster too, but at the cost of hundreds of thousands of more Americans dying. But I would guess if we can keep up and decrease vaccine hesitancy, we should reach community protection levels mid to late summer. So thank you very much.
Okay, David, thank you. If you had to pick out your biggest concern right now with all the myriad of issues that are going on, what would it be?
My biggest concern right now is vaccine hesitancy. We have vaccines that are very effective, are very safe, particularly when you compare the risk-benefit ratios to these vaccines. Unfortunately, vaccines like wearing masks in part have become a political issue. We already know that there's increased vaccine hesitancy among Black and Latinos for a variety of reasons. That to me is my biggest concern.
Okay, so going on to a couple of the questions. Someone comments about vaccine hesitancy with regard to fertility in young women. We've talked a little bit about this before, but kind of an update there.
So there is no reason one to suspect that any of the vaccines will affect fertility. They don't enter eggs or sperm. They don't cause any genetic consequences in people or in animal models. There have been tens of thousands of women now immunized who are pregnant. At least in the short term, there have been no concerns among the pregnant women having problems or problems with the fetal, such as early fetal loss, stillbirths, or other problems. Now, many of those women have obviously not been followed to full birth, but there are no signals at the present time that the vaccines have any issues related to fertility or related to any harms to the pregnant woman or the fetus. So I'm not expecting any.
Okay, so there are a couple of questions put together. What's your expectation for any individual after they receive the vaccines as far as antibody response? Is there a reason to get tested for antibody response? And then what's the likelihood of someone not having antibodies, and what do you do about it?
So it generally takes about 2 weeks to begin developing an antibody response, and even one dose of vaccine is about 50% effective after about 2 weeks. But of course, everyone should get 2 doses. If they're on the Moderna or Pfizer vaccine, you get up to 95% effectiveness. Again, it takes about 2 weeks for that full antibody response to develop. No, there's no need to get tested. Virtually everyone who gets the vaccine has an antibody response, but we don't know what the protective level of antibodies is. So for hepatitis B, I can tell you if you get tested, 10 million international units of antibody against hepatitis B surface antigen, you are protected. But we don't have that correlative immunity for vaccine, so there's no point in getting tested. And we don't have any standardized ways of measuring T cell response, which is also important and is developed by the vaccine.
Okay, so there's a couple of questions around the future and COVID. You mentioned earlier you didn't necessarily anticipate that we would need a booster, but we may not need something on an annual basis like the flu vaccine. Expound on those thoughts a little bit more. Sure. What you anticipate, 3 to 5 years might look like related to COVID.
So going down the line, COVID, first of all, will be with us. There is the chance the virus will mutate to cause less severe disease, because it's certainly not in the virus's interest in killing off its host. And that's certainly been true. The other 4 types of COVID or coronaviruses we have cause disease about the same, morbidity, mortalities, influenza. So it might turn out to be less virulent in the future. Yes, I think we will likely get a booster dose late this year or early next year. And if the COVID remains equally virulent, I would think that we would probably need booster shots every 3 years, but that's mostly really dependent on the emergence of variants. I do believe that the duration of protection in the antibodies will be, and this is just a guess, we don't have data, but lasting for up to 5 years. And so the main reason for a booster would be the variants, not because of loss of antibodies, although that's still possible.
Okay, so again, trying to put a few questions together, David, you talked about in the CDC recommendations for those that are vaccinated, the family bubble. But now my wife and I have been vaccinated, we're in our bubble, but we want to get outside our bubble. And so what should we do? What kind of precautions should we make from a practical standpoint?
So the first thing is, obviously, you can go out of your bubble now into other small bubbles, provided everyone is fully immunized. I would caution you not just assume everyone's immunized. The majority, so 2/3 of America is not. I think you want to keep the bubble small. And of course, again, the biggest concern is if in your bubble or the other bubbles are the mixing of children who have not been vaccinated, has some concern. And we've already seen that the biggest risk for K through 12 schools is actually not being in school when they're masked and physically distancing. It's participating in sports without masks. And so the biggest risk for all of us, I think largely most businesses can reopen. And in fact, most of us can go shopping safely with wearing an appropriate mask and physical distancing. The biggest risk is activities for which people don't wear masks, indoor eating, sitting in movie houses and eating popcorn, cruise ships with large numbers of people. So those are the biggest risks, and those, particularly if you're vulnerable, are the things to avoid.
Okay, thank you. So one other question about the antibody treatments, the preventive treatment. How do you see that working out in future years as far as that thought process of treatment?
I think these will be the stopgap method until we develop better antivirals. Those are hard at work. Dr. Billy Fisher, Mike Cohen have been studying an oral pill here at UNC. I haven't seen any of the data, but the trial is either complete or should be completed soon. Ralph Barrick has developed new antivirals that are more effective. So until those come online, the monoclonal antibodies are the best. And of course, they only are still temporary, so they only work for a short period of time, unlike active immunity. I do believe we'll be able to develop new monoclonals as quickly as variants arrive. What's new about them, I think, are one, we're going to use combination monoclonals, not a single one. And two, Mike Cohen led a study of looking at monoclonal antibodies for pre and post-exposure prophylaxis, which we don't have. And I think we will be able to use these drugs like in a nursing home where you have highly vulnerable people. Once there's infection there with many people exposed, we will be able to immunize people either who have already been exposed to before exposure and dramatically lower infection rates and deaths. So that's what I'm thinking, and I think we will see the FDA release the monoclonals in the next 6 weeks for that purpose.
Okay, David, one last question, I promise. You've been working literally 7 days a week for 14 months. We tried to get you to take some time off and you kind of did, but it still was hard. So you've had a whole bunch of like aha moments in the past 14 months. What's been your biggest surprise about everything that happened?
I would say first is the fact that it was never a matter of if we would see a pandemic, but when. But I never really envisioned we would have a pandemic that would rival the 1918 pandemic in terms of worldwide spread and devastation that we've seen. The second aha moment was all the lessons that we know about in infection prevention to prevent people from becoming ill really work. And we've known this for a long time. I mean, I want to point out that we've never had, I'll say it again, we've not had a single healthcare provider in our COVID unit, our respiratory diagnostic center, our emergency department develop COVID from taking care of a COVID patient. So we know how to protect our healthcare employees from disease. So that was an aha moment that all the things we've learned over 50 years in infection prevention really work. And the final aha moment was, you know, we're really getting good at developing things like vaccines and diagnostics. The speed of with we developed diagnostic tests and then developed vaccines, I would not have predicted we could have done that this fast a year ago. It is just an amazing tribute to our scientists to have developed and actually mass produced a vaccine that works so well and is so safe so fast. So that was another aha moment.
Okay, David, thank you. And thank you for updating all of us, but also sharing some of your personal stories and your personal insights. So I'll turn it back over to Leslie.
Thank you, Dr. Burks. I just want to extend my thanks too to Dr. Weber and Dr. Burks for hosting us today. I hope you found our time together helpful and informative. As we close out, I just want to make mention of a couple of things. Some resources will come up on the screen here in just a second. If you are inspired by what you heard today and are called to help us with our COVID-19 response, I hope you'll consider making a gift to our COVID-19 response fund. And we've also put up on the screen our link to our COVID-19 UNC Health's main site. So if you want to have more information on what you've heard today, please feel free to visit that website. And then I also want to just say that our Game Changers is going to continue. We're going to expand this series to cover other topics outside of COVID-19 as we start to try to move into the future, and we'll cover things like our cancer programs, cardiovascular medicine, and so much more. So stay tuned for invitations to more COVID-19, or excuse me, more Game Changers events. And that is all for us today. Thank you so much for joining us, and have a great afternoon.